Saw palmetto does work for guys. You heard that from Wendy too. However, it works too well some of the time. And then we have the beta-sitosterol, and oddly enough, quercetin can slow things down too. Now, the over-inhibition, why do I worry about it that at all? Because the New England Journal of Medicine are authors here. This was a letter to the editor, darn it. It wasn't even an article, but here's what they pointed out. And you'll find it in the New England Journal. They were reviewing something called the prostate cancer prevention trial. Now, you probably know that if somebody had out there an agent which really would effectively prevent prostate cancer, and it was a patent medicine, there would probably be a TV advertisement about it. Probably. So, the prostate cancer prevention trial was early 2000s. 18,000 guys, PSA of less than 3. Finasteride versus placebo. Well, in the finasteride group, there were only, quote unquote, 18.4% cancers. In the placebo group, there were 24.4% cancers. That's statistically significant. They had a big enough group. Oh my God, finasteride prevents prostate cancer. Why isn't it on television? Well, because 37% of the finasteride group had higher Gleason score, much more aggressive type cancers. And in the placebo group, it was 22.3%. And the television commercial would have said this: take finasteride. You have less of a chance of getting prostate cancer, but if you do get it, you're more likely to die. And that TV commercial would not have gone over well. So that's why we never saw about it. Now, there has been, I kid you not, somebody went back, probably funded by the drug company, and rejiggered all the statistics and said, oh, and put this in print. Oh, that's not really the case. Every man should take finasteride anyway. You go back and look at that. It was an entire rejiggering of statistics and fits well within Mark Twain's remark of there are lies, damned lies in statistics. So I'm still sticking with this, and I think I've got in here some slides to show you why. Well, first, here's something from Cochrane database. By now, I think we've all heard of Cochrane database. 5-alpha reductase inhibitors reduce prostate cancer risk, but may increase the risk of high-grade disease in men who are undergoing regular screening for prostate cancer. So basically, they can't say whether taking finasteride all the time is going to be a good idea. I have this strange idea that if nature had intended all of us guys to have finasteride in us, we would have it. Or maybe it would have put it in some plant, and some wise folk medicine person 10,000 years ago would have figured out that this plant was good for guys, with a plant with a finasteride in it. But that didn't happen. So there's the citation to the Cochrane database systemic review, and what they're saying is basically information is inadequate to assess the impact of 5-alpha reductase inhibitors on mortality. Now, here's the pathway, and this was pointed out in the Imamov letter in the New England Journal. Testosterone, 5-alpha reductase, dihydrotestosterone. Why? This is a proliferant, a dedifferentiation agent. This stuff is potent. And in addition to getting a guy's head disorganized, it gets his cells disorganized. Yeah. The DHT, very, very potent androgen. Did you know that in Europe, a lot of the andrologists just simply up and prescribe DHT for hormone replacement? No kidding. And they don't seem to be seeing an excess of cancers. Why? Well, that's not done over here, of course. The next step goes to the 3-beta-androstenediol stuff. Look at that. It stimulates estrogen receptor B, not alpha. And we know that that's a good idea. It's a redifferentiating agent. It reorganizes the cells. So we go, oh, gee, have we heard of the pathway from estrone through 16-hydroxyestrogen to estriol? A similar situation here. The 16-hydroxy, bad news mostly. As Wendy said, not always. It helps us to have bone. If we don't have enough of it, the bone isn't as good as it should be. But still, it's mostly a bad girl, the 16-alpha. But then it emerges into the light as estriol. Same situation over here. This stuff is a good one. It's an anti-differentiation agent. All right? So if we inhibit here too much, what happens is something like this. Here's the patient on one of the 5-alpha reductase inhibitors. And this is all their estrogens. I'm not quite sure why we have this page, but we want to be complete, I guess. And here's the same person. And take a look here. Testosterone, 88. Very effective Avodart, 5-alpha DHT, 22. What's the androstenediol? 8. So what have we got more of? We got more of the DHT than the androstenediol. And when we have more DHT, we have more of a dedifferentiating, possibly disorganizing agent that just might give us more cancer. And we have less of the next downstream metabolite. So what we want to do before we go around measuring DHT all by itself and telling people, oh my God, you got too much DHT, measure the next step. That would be like measuring somebody's 16-hydroxyestrogen and saying, oh my God, you got too much 16, and not measuring the estriol. Because if the person has more estriol than 16-alpha-hydroxyestrone, or if a person has more, I mean, after all, the majority of guys don't get prostate cancer. I mean, it's getting close to be a small majority, but still a majority of guys don't get prostate cancer. Why shouldn't they? They all make DHT. Well, they all metabolize it through to the 5-alpha androstenediol or the 5-beta androstenediol too. So one offsets the other. And, okay, that's somebody on Avodart. And, of course, these are the markers that are used for indicating the 5-alpha reductase inhibition, and they're way low. Oh, he went off his Avodart, and look what happened, again, avoiding the estrogens page. Why, his testosterone's about the same. It was 88. His DHT is 19, and now his androstenediol has come up to 39. Now, that's only a couple, 3 months off Avodart. He basically didn't want to pay for another test, so we didn't get one. Couldn't afford to give him a freebie at that time. But the longer he stayed off Avodart, I'm sure at least this was maintained, I can be sure of, and maybe it even got better than that. And with no Avodart, look at his markers of 5-alpha reductase inhibition here and here. And you keep hearing about aromatase and 5-alpha reductase. What happened to all the other enzymes? Why, there's just not as much research as we'd like to be able to manipulate those very, very well either. But just for fun, let me give you another one. We've heard of the cortisol, cortisol transform. And cortisone can be mobilized and transformed into cortisol, right? Why do women gain more weight after menopause? Oh, their estrogen went down. Why? Could estrogen inhibit that step? Yes. Estrogen inhibits, this is research work from the University of Oregon, by the way. The step cortisone to cortisol, 11-beta-hydroxysteroid dehydrogenase, that step is inhibited by estrogen. So ladies don't have as much. If they happen to use, what these people at the University of Oregon did was to measure premenopausal women, postmenopausal women, and postmenopausal women on hormone replacement. And what they found is that the pattern was quite similar between women on hormone replacement and women who were premenopausal, in that there was a lot less urinary free cortisol in those two groups. So we can inhibit that particular cortisone to cortisol step with estrogen. And this is just for fun, because I'm tired of those two enzymes, because I've got to talk about another enzyme for a moment. And what else inhibits that particular thing? Why, growth hormone, HGH. It inhibits the cortisone to cortisol step. Now, there's another 11-beta-hydroxysteroid dehydrogenase. It took me 5 years to learn to say that fast, okay? It takes a while. And that's why I keep my chart on my desk, and that's why I can call up over at the laboratory and get a consult with one of the doctors over there in case I'm confused.